insight into how we can enhance cataract surgical outcomes, where we are going to start with biometry, then with hard cataract, posterior polar cataract, loose bags, toric intraocular lenses, LRCS, so that in each and I have requested my speakers to essentially present them as pearls, top pearls as to what they would employ in the day-to-day practice. And subsequent to each speaker, we'll have about 5 minutes of panel discussion as to the salient features that have been made, and inputs from the audience is also most welcome. I do appreciate you all staying back. It's 4:45 in the evening, but we'll ensure that it's worth your while. I think you should start. We'll begin the IC now, and I request Dr. Chitra Ramamurthy, who is the Medical Director of the Eye Foundation Group of Eye Hospitals, to talk to us about top pearls in biometry. Needless to say, you have to get the biometry right to get the results of cataract surgery appropriately. Whatever be the quality of phacoemulsification or quality of lenses, if your basic biometry is not erroneous, then the results are going to be compromised. So let's start from the beginning. Over to you, Chitra, biometry.
Very good afternoon to one and all of you, and we truly hope to make it a practically relevant webinar for one and all of you. And my due in the next few minutes is to talk on my top pearls in biometry. And there's no financial disclosure. So basically, today we are all charged that we have to deliver the best in our practices, and success is how you're going to hit the target, how you're going to deliver what you have promised to the patient to give him spectacle independence for distance, intermediate and near, or any one of those. So how well we were performing, this was a study which was done way back in 2017, wherein they compared the third generation IOL formulae and with the modern generation, the fourth and the fifth generation formula. And what they found was, by using the earlier generation formula, there was only 78% of them were getting able to achieve within plus minus 0.5 diopter of the target refraction, as against the use of the present day latest generation formula, the fourth and the fifth, where 90% of them are within plus minus 0.5 diopter of achievable target. The worst thing is that if you use an older generation formula, you might get away with it in normal eyes, but it becomes challenging in those unusual eyes, like eyes with a large axial length or a very short eye, or if it is a post-refractive surgery eye or a keratoconic eye. So the first pearl is the formula factor. Now, do we try to use different formulas and try look at the repeatability of the values, or do we look at just one formula which you have time tested in your set of patients and assume it to be the one formula factor which gives you the target emmetropia or the promised target refraction you have for all of these patients? So if you just try to retrace, we know that the first generation formula was based on theoretical geometric optics. This is a theoretical formula. Then came the regression formula, which came on the analysis of the post-op refractive results. And then came the divergence formula, which started off with two variables early on, just the axial length and the K value. And then came the anterior chamber depth. And then more and more variables were added on, so that you were able to pin the exact emmetropic outcome for these patients by defining the exact effective lens position, or where the lens sits in the bag. And then came the artificial intelligence and the Hill RBF and the Clarks, and then came the ray tracing formula, the phaco optics, Oculus, and a lot more. We did a study comparing the third generation formula with the Barrett Universal 2, again way back in 2022, and what we found was that with the Barrett universal formula, at least 96% of the patient were within plus minus 0.5 diopter, as against 93% with the third generation formula, and so on. And the kind of repeatability and the high percentage values with the Barrett universal formula should augur all of us to move towards this in our respective practices. This is again another study which has compared the Hill RBF with the Barrett Universal 2, and what it again reiterates is that 92% of them are within plus minus 0.5 diopter of target diffraction if you use the latest generation formula. If you try to understand the Barrett suit, it comes, and that too with the TK component, that is something which is the total keratometry, or the anterior and the posterior corneal astigmatism is factored in, which is a value which you get in the IOL Master 700, or else you could also access the website, the APACRS or the ASCRS website, and get to access these formulas, wherein you have the axial length, corneal power, anterior chamber depth, white to white, lens thickness, lens factor, all of these factored in, which gives you the exact effective lens position or closest to the effective lens position of the IOL in the bag. However, an optimal surgical outcome is also mandated. It also takes into account the principal plane of the lens. That is, it could be a biconvex lens, an equiconvex lens, or paleoconvex lens, or a meniscus lens if it is a high myope. So based on that, the principal plane of these lenses would differ. What is the principal plane of the lens? Is the distance from the endothelium to the central optical axis of the IOL sitting in the bag, and this kind of accuracy is possible with the Barrett universal formula or the more recent formula. If you have access to the IOL Master 700, it is able to measure the total keratometry with the help of the swept source and the B-scan biometry, which gives all the values on the anterior cornea and interpolates the value on the posterior cornea and gives you the total TK value, TK universal, TK toric, or TK 2K TK. And what we also have to understand is, supposing you have used a formula like a holiday formula or any other formula which has mathematically assumed the posterior corneal astigmatism, in those eyes, if you further add on the Barrett TK, then you might end up overcorrecting, and that has to be kept in mind. So whenever a patient comes into our practice, before we even go and do an applanation tonometry and disturb the tear film, we would actually take the patient, if he's interested in cataract surgery, do a biometry to understand what the true values are, and if it is an astigmatic error, we would veer the discussion towards a probability of including a toric IOL calculation. When we try to understand the errors in biometry, earlier on it was axial length, keratometer, and effective lens position, and these were a high percentage of errors which could happen. But now with all the optical biometers, we are bang on in your axial length, and it is the K and the ELP. So it becomes, especially with the K, you should do repeat the measurement in two modalities to know about the repeatability of the measure. And the important thing is, the FACO study tells us that 60% of the patients who are actually asymptomatic do have dry eyes, and even up to 63% have a tear breakup time less than 5, and 50% have a central corneal staining. So even if the patient looks okay, we need to assess, know that they could have dry eye status, and that could bring in an error in a keratometric reading. So a Schirmer's testing becomes absolute mandatory, and a tear breakup time. Now let's look at this patient. It was initially showing a TK of 1.63 and an artifactual defect and those fishtail appearances on the IOL Master 700, but after treating the dry eye, the astigmatic value was only 0.3, and that shows the amount of difference which could come up in our toric IOL power calculation. Again, this is another study which tells us that you should ask the patient not to blink, do a keratometry, and if the standard deviation is more than 0.3 diopters, more than 0.03 millimeters or more than 0.2 diopters, it could be a dry eye. Then treat the dry eye and repeat the biometry. If it is not dry eye but still the standard deviation is off, then it could be a keratoconus eye, could be a PMD. Then you have to do a tomography, just not a topography. And if there is astigmatism, put the patient on the toric calculator and use the latest generation formula. It is always important to measure both eyes in every patient because it gives us a tons of information. Here the axial length is 21.9 and the other eye is 22.6, and the keratometer in one eye the IOL power was 22 and other eye it was 25. Now that is grossly off the axis. So what it indicates is that you, in such situations, you repeat the biometry, and then again those errors, if you do it carefully, take care of the tear fill and repeat the measurements. It was actually 22 in both eyes, and that kind of care in biometry is absolutely indicated, and you need to ensure that your technician does that. And if it is done on an immersion, you should see whether all the spikes are normal, the standard deviation is less than 0.6, there's repeatability in your measurements, and those orbital spikes are there. So everything has to be looked into. Even if the other eye is pseudo-phakic, you need to see whether the anterior chamber depth, the axial length, the K values, they would be repeatable in both eyes. And if there is an asymmetry, then you know it could be an amblyopic eye, and you should have counseled your patient accordingly. So these are some pearls. The pearl 4, we need to understand whether the astigmatism is against the rule or with the rule when you are advising a toric. Now, we all know there is something called posterior corneal astigmatism. In 90% of the cases, it's against the rule, and and this creates a minus lens in the horizontal meridian. If the posterior cornea is against the rule and the anterior cornea against the rule, then the total corneal astigmatism is going to be more. But if the posterior cornea is against the rule and the anterior cornea is with the rule, then the total corneal astigmatism is less. So what you see is, if the patient has an against the rule anterior cornea, more often than not, it says that you need a toric IOL if that astigmatism is even little lesser. But if the anterior cornea is with the rule and the total corneal astigmatism is actually lesser, then it says that no toric is needed. So how low do we go? I would put my patient on a toric calculator and tell him this is astigmatism with the toric IOL correction. If the toric calculator says it could be done, and if the patient could afford to go for those lenses, he could go for a complete spectacle independence. The threshold for a toric IOL, toricity correction becomes even more necessary in a premium IOL, which will not tolerate even more than 0.75 diopter of astigmatism not being corrected. In atypical eyes, like in a post-LASIK eye, there are different ways, ASCRS calculator or the ORA or the Barrett-Truquet and the Higgis. But what we find is the Barrett-Truquet seems to be doing extremely well. And multiple studies have shown us that myopic classic does better than PRK than hyperopic classic, and Barrett-Truquet toric seems to make sense in 75% of these situations. You need to feed in whether it was myopic classic or hyperopic classic when you go onto the sheet, and also need to feed in the data whether it was calculated on the Pentacam or on the IOL master, and feed in these data. And this is a study which says that the Truquet TK, in 70% of the cases you get target refraction of within plus minus 0.5 cylinder as against the rest. But what is also important in a post-LASIK eye is whether within the central 3 millimeters it's a regular bow tie, whether when you're trying to check the K value in two different modalities, the difference is less than 0.75, and all of these becomes important. And actually, if it is a post-RK and if the patient is constantly using a rose K lens to take care of his irregular astigmatism, you totally avoid a toric IOL calculator in these eyes. So again, if it comes to keratoconus, the best formulas would be the Barrett calculator, Truquet formula, followed by SRGT, which incidentally gives a myopic outcome, and because you can end up with hyperopic surprises, because in keratoconus, both the anterior and the posterior cornea relationship is altered, and that has to be kept in mind. So finally, we have done the best of IOL formula, best of calculation, best of technicians, but the ELP has been seen to shift post-operatively too, and this was a study which showed that 17.6% of the patients, the anterior chamber shift occurred of more than 0.1 millimeter from 1 hour to 2 months. So actually we try our best, but we may not be hitting it, but then probably some breakthrough technology like the light adjustable lenses, which seems to be so promising, where post-operatively you can adjust the residual refractive error, may be the future. But at the present day, to get that kind of promise of a spectacle independence for the patient, either for distance or for distance intermediate and near, is what is going to differentiate your practice from your neighbor's practice and your success ahead. Thank you very much.
Thank you, Chitra. That was a very comprehensive overview of what's current in biometry. Any questions for her? Any queries from any one of you? Any comments from the panelists?
So just to add or reiterate 2 points that were mentioned during the talk, I think the fact that repeatable measurements are always important in biometry, and if you were to have outlier values or any asymmetry between the two eyes, you'd always want to repeat the biometry and see if you're getting the same values. And at the same time, when we also emphasize the importance of a trained technician for something like immersion biometry or manual keratometry, even for the IOL master, there needs to be someone who is trained, who can recognize the pattern of the Myers that reflect on the cornea, because very often in the presence of a small pterygium or some of ocular surface disease, one can often have blurred Myers which can quite adversely impact the kind of astigmatism that you get. And this again you can really confirm by repeating the values once again, and you would find gross disparity, and then you take the necessary measures before moving on to cataract surgery. So repeatability and symmetry, as with any investigation, are very important when we proceed taking these values, because what values are taken, the formula may not matter as much, but if the values themselves are wrong, then it's garbage in, garbage out, you'll not get a good result.
Over the last half a decade or so, we have found that, the Barrett group of formula works very well for us, whether it's the Barrett Universal 2 or the Barrett Toric calculator or the Barrett True K for patients who have undergone prior refractive surgery. That seems to give fairly reliable results. This, in combination with a good optical biometry, gives you almost a reasonable surety that you will be achieving your target most often, at least in about 90% of your cases. An investment in optical biometry is a good idea. Just in case you do not have one, still you can do an excellent immersion A scan, an autokeratometer, and all the entire Barrett suite of formula is available in the ASCRS, APSCRS websites. And you can feed in these values in these formulae and then have the benefits of that. So even now, of course, we have equipped all our centers with an optical biometer. But even before doing that, it was a norm for us to stick on to this, and it seems to, because there's such a large gamut of formulae available, oftentimes you're wondering which one to choose, which one will work well for you in your hands. And yes, there are advances that are possible, but presently we feel that this formula seems to work quite well. And now we go on to Dr. Shrish Kumar, who is a medical superintendent of our Eye Foundation Coimbatore branch, and he's also a very acclaimed cataract, refractive and cornea surgeon, and he'll be talking to us about my top pearls in posterior polar cataract.
There is a question for the previous talk.
Yes.
Yeah.
Hello. Yeah. Good evening, ma'am.
Yeah.
Ma'am, I wanted to ask whether, like, normally a patient comes, we see the patient, we dilate them,
Yeah.
then we see the cataract, fundus, all that.
Yeah.
And at times they don't fix it at the same moment, but we take the IOL power depending when they come back, So post dilatation, when we take the IOL power
Yeah.
on an optical biometer, does that have an effect on the toricity? Because at times we feel that the cylinder powers when we, pre-dilatation.
I think best measurements would be taking them on an undilated pupil. That would be the best way to go. Even if you have done all the tests, you could repeat the test once again when the patient comes prior to the surgery in a routine situation. But for a toric IOL, you may have to call him again at some time because you may have to order these lenses.
This is nicely said, but then, practically, most often the patient comes up for a biometry at the end of an examination, especially if he or she is fixing surgery on the same day.
Yes, sir.
And as far as astigmatism is concerned, it's entirely corneal. So dilatation should not be having any impact on it. Lens tilt hardly impacts significantly on this. So in case you find a gross difference between the two eyes, the astigmatism and the glass power are not in sync, maybe it would be a good idea, or you suspect dry eyes, to repeat the biometry. Otherwise, most often we go by what we see on the first day.
Thank you, sir.
Do you have anything to add, Gaurav?
So I think you covered everything so well. I just had a question. Are you using ray tracing for these post-refractive surgery eyes routinely, because you have an anterior also?
Ray tracing.
Has it made any sense? Because it does give you a good toric calculation and the other thing, but are you finding it predictable and kind of useful? Because we've been trying to make sense of it. Sometimes it works beautifully well in post-refractive surgeries, and sometimes it's totally off. So
Yeah, what you say does make sense, but we would have tried in few numbers. For all patients, we don't keep doing it the paucity of time. So we have seen consistent repeatability in Barrett 2K, and we stick to that.
okay.
I know you have done a study with the Hill RBF.
Yeah, that was Hill. Even Hill RPF for me works extremely well, and I continue to use it. In fact, my printouts on the Lenstar are for the Hill RPF and the Barretts, and on the 700 they are usually for the Barretts alone. And on the Anterion, of course, we do ray tracing only for post-refractive surgery eyes basically. But on the IOLMaster 700, typically we'll have two prints. One is for the K and one is for the TK, and for both the toric calculations. So we quickly have a look whether both are kind of consistent or not, and then we decide what we want to use or investigate further.
Thank you. At the outset, I would like to thank Dr. Ramurthy for giving me this opportunity. And my topic is top pulse in posterior polar cataract management. We all know posterior polar cataract is a rare form of congenital cataract, and the incidence of posterior polar cataract is around 3 to 5 per 1,000 cases of cataract we operate. And the most common problem what we encounter is posterior capsular rupture with the subsequent nucleus drop due to abnormal addition of posterior capsule to the polar opacity. And there has been a significant improvement in the outcome. The PCR rate has come down drastically in the last couple of years. This could be because of the better understanding of the condition, better diagnostics we have, and improvement in the surgical skills of the surgeons. So now the posterior capsular rupture rate is roughly around 4 to 6%. I'm going to show a series of videos of phacoemulsification in case of posterior polar cataract. We had a long discussion in the previous session. We had almost half an hour discussion on posterior capsular cataract management. Here, we're making a moderate sized rexis. This is around 4.5 to 5 millimeters diameter. This is just because, and then injecting fluid. This is a hydrodelamination, just going just below the rexis margin and injecting fluid into the substance of the nucleus. And I usually even delineate with the Sinski hook so that my nucleus will be free in the bag, epinuclear bag, and then emulsify the nucleus. This is a very soft cataract, and maintaining the chamber is extremely important. Inject visco whenever we come out of the antechamber, and now the epinucleus is separated from the cortex by again a jet of fluid which separates it, and you aspirate the epinucleus and try to maintain a chamber throughout, and inject visco whenever you come out. Don't allow the AC to collapse, and do a 360-degree cortical cleanup using bilateral bimanual irrigation aspiration cannula, and inject the lens into the bag. There is a small debris. I'm not going to touch it. It's in the posterior pole. And again, emphasis on hydrodelamination. So you stay in the substance of the nucleus at the junction of the nucleus and epinucleus. You create a gap here by injecting small amount of fluid, and then try to inject fluid in that gap. So you get a nice golden ring. You can even do multi-quadrant hydrodelamination. slowly inject a little amount of fluid and try to separate it completely from the epinucleus. Then it becomes easy for you to manipulate this nucleus. And this is a technique. The other technique which was described by our own Dr. Vasevada, inside out technique, where you create a trench and then inject fluid into the walls of the one of the wall of the trench, and that will delineate the nucleus, and then you can follow your routine step. This is a case, it's a moderately hard cataract. It's not as soft as the previous cases, and I'm trying to do hydrodelamination here, but was not able to be successful. So I'm planning to do a mechanical delamination and using a Sinskey hook, just delaminating the nucleus from the epinucleus. It's a grade 2 to grade 3 cataract, and then you do your chopping technique, in situ chopping, and try to separate the heminucleus from the epinuclear cushion, and do all your manipulation in the cover of epinuclear cushion, and using moderate parameters, I usually complete the procedure. And this actually has led to me doing a new procedure. This is a mechanical delamination. I have started doing it more often now, and this is the depiction of the same. You have a clay model here. So we are going to delineate the nucleus from the epinucleus using a Sinskey hook or a chopper, and then you emulsify the nucleus. The similar procedure of delineation of epinucleus from the cortex is done. Once that is done, you either emulsify or phacoaspirate the epinucleus, and then do your 360-degree cortical cleanup and inject your lens into the bag. So in this way you are completely avoiding any hydro procedure which you usually do, so that the accidental seepage of fluid into the subcapsular capsular space can be avoided. This is a soft cataract, grade 1 to 2 PPC, and I am doing a mechanical delamination using a Sinskey hook. So I am delineating endonucleus from the epinucleus, and now trying to delineate epinucleus from the remaining cortex, and doing a phacoemulsification, chopping and doing the emulsification part within the capsular cushion, epinuclear cushion. Do a layer by layer aspiration of epinucleus, cortex, and cortical cleanup. Follow all the other parameters which you usually follow, and maintain the anterior chamber. Don't allow the AIC to collapse. This is another case. The AIOS-OCT shows there is a defect in the posterior capsule, and this is the case. Again, it's a very soft cataract, but the patient was symptomatic. It was right in the center, and it was progressive in nature. So went ahead with the phacoemulsification, and I have done a mechanical delamination. No hydro procedure was done in this case. Since it's a very soft cataract, I could aspirate it. The epinucleus was aspirated using IA. And then you can see the defect here. It is a small defect which is actually fibrosed defect. there is a hole in the posterior capsule, and you could maintain it. It has not enlarged during the maneuvers, and you could place the lens in the bag. It's a multifocal toric lens which was implanted into the bag, and it's stable. No vitrectomy was needed because there was no vitreous prolapse. Another case of PC defect, this is an obvious PC defect here, and this is the case. You could see the debris of cortical debris in the patellar fossa, and this is the case. And again, I did delamination, mechanical delamination, moderate sized rhexis, and very soft cataract. You can aspirate it. That's what I have done here. You can see a defect here. This is a PC defect, but there is a lot of debris and in the anterior vitreous face. This patient definitely requires anterior vitrectomy, even though there was no obvious vitreous prolapse from the capsular defect. And I'm doing a posterior capsulorhexis. And the posterior capsulorhexis is completed, and the lens is placed in the bag. This is again a multifocal toric lens. The lens was injected into the bag. Once you have a posterior capsulorhexis, it's easy for you to manipulate. So the lens is very well placed, and it's stable post-operatively. You can see the posterior capsular rhexis margin, and this is anterior capsular rhexis margin. Another case of posterior capsular defect, this particular patient, when I injected visco into the antechamber, I could see a split happening. And this is the split that has happened during injecting of visco into the antechamber, and so you have a posterior capsular tear right from the beginning. So one has to be careful, and I did a mechanical delamination and layer by layer removal of the cortical material, and there is a vertical split which was extending from the limbus to the limbus, and I did the anterior vitrectomy. This is an old case, so I have not used tricot here, but I could place the lens in the bag. So, to conclude, one has to be very careful while handling a case of posterior polar cataract. You have to do a thorough slit lamp examination to see the posterior capsular status, and if you have access to anterior segment OCT, you have to assess the posterior capsule and avoid any positive pressure during surgery, and provide a closed chamber during all the stages, and maintain the contours of the cornea and globe, minimize turbulence and pressure in the anterior chamber, prevent iatrogenic PCR and or extension of pre-existent PC defect, mechanically cushion the polar opacity throughout, and reduce your parameters while doing the surgery, and avoid capsular polishing. Thank you very much.
Thank you so much, Rish. I mean, I think you nicely brought out all the various aspects of posterior polar cataract management. Recently, we have conducted a study, and our approach towards posterior polar cataracts has gone a sea change with the use of anterior segment OCT. Dr. Tamiyarisi actually did the study, and I would like her to comment on this, how AIOS-OCT has impacted our management of
No.
Good evening all, and we know that preoperative use of AIOS-OCT in polar cataracts has a high negative predictive value. It means that if the posterior capsule is traced beyond the opacity, it is unlikely to rupture during the intraoperative period. And Titial et al. Sir has demonstrated in a study in 2020 itself that using intraoperative OCT, he has identified a low risk variant where they have done hydrodissection, and out of the 19 eyes, he has reported no instance of PCR. And in the study, they have correlated that preoperative AIOS-OCT image correlated with the intraoperative OCT image. So talking of hydrodissection in PPC, though it looks controversial, we took the scientific evidence of these two what is there in the literature, and we designed a study where he used preoperative AIOS-OCT, and if the PC could be traced beyond the opacity, we did a gentle hydrodissection and nuclear rotation. And if the PC could not be traced beyond the opacity, we did hydrodelineation and did not do any nuclear rotation. And we had around 56 eyes in the type 1 PPC, and we had only one PCR, and in the second group where the PC was not intact, we followed all the routine precautions, and we had 4 eyes of PCR, which was statistically significant. And the negative predictive value with hydrodissection in our study was 98.1%, whereas the positive predictive value was 25%. It means that not all cases where the PC was not traced had PCR. It could be because of the dense polar opacity, which has not allowed us to image the posterior capsule. So these was study results.
Dr. Abhay, any comments? You have been always mastering PPC.
I must say I didn't understand everything, but I agree that intraoperative OCT, if you have it and if you practice it, you can use it. Professor Titial has shown it and their group, and you are doing the same thing. But from a general surgeon's point of view, and I don't have intraoperative OCT, I don't use it. If you have a posterior polar cataract, and even if you're scanning a scan or whatever shows intact capsule, I would not hydrodissect. We never know, because I have had the bad experience where the whole surgery is over, everything is there, and you just hydrate the incision and the capsule ruptures. So do not trust, I don't trust posterior polar until I remove the speculum out of the eye. It will rupture any second. So if you have this kind of a controlled imaging and you have experience, go ahead. But I would be reluctant to suggest everyone, it's better to err on not doing it. You can always do it if you need to do it some stage in the surgery. That's my general comment. But I didn't understand what you were saying. It's my fault. I didn't attend that much. I'm sorry.
This was the general concept, and that's what we are practicing for almost 3 decades. Recently with the AIOS-OCT, not the intraoperative OCT, but the ASS-OCT, Swepsos-OCT used for AIOS-OCT, we're able to get a very clear delineation as to whether the posterior capsule is intact or not. It's as Dr. Vasavada pointed out, it may be intact, but still there could be, it could easily give way. So all your maneuvers have to be quite gentle, but we have started hydrodissecting these eyes where the posterior capsule is intact. And as Dr. Tamil pointed out, just in 1 case out of 56, we had a PCR in these cases.
I think, the important thing is you need to have a high definition OCT, because earlier generation OCT will not give you a good picture. So if you have a high definition anti-segment OCT, gives a very nice delineation of all the structures, morphology of posterior polar cataract in relationship to the posterior capsule. Even those cases what Dr. Abhay was talking about, if I do hydrodissection also, I will not rotate the entire the bulk of a complex. I'll again delineate. You have a core of a nucleus. You maintain the epicortical cushion till the end without disturbing that. So you have a very easy time to remove that epicortical cushion, because most of the time the damage to posterior capsule happens when you are trying to remove the epicortex. If there is a fluid delineation, it comes out very easily and you prevent the disruption happening. That people should understand.
Excellent. Thank you. And now we have Dr. Rakshit, who is going to be speaking about management of a loose bag, the top pearls in that. Dr. Rakshit is a cornea, cataract and refractive surgeon at the Eye Foundation.
Good evening, everyone. So thank you for this opportunity. So I'll be discussing top pearls for zonulopathy or managing zonulopathy during cataract surgery. I do not have any financial disclosures. So when we talk of zonulopathy, we often categorize them into generalized forms of zonulopathy where the involvement is diffuse and involves all the zonules, versus a focal or particular segment of zonules that are involved. And the prototype example for generalized zonular weakness is pseudoexfoliation, patients with high myopia and retinitis pigmentosa also show generalized zonular weakness. The prototype example of a focal zonular weakness is post-blunt or penetrating trauma, Marfan syndrome, and patients with coloboma. At the same time, we also talk about progressive versus non-progressive zonulopathies, and this can also influence the management and what devices we use intraoperatively to stabilize these bags in the long term. And of course, the generalized zonulopathies tend to be progressive, whereas the focal zonulopathies tend to be non-progressive. So a lot has been written about the preoperative assessment of zonulopathy. One must look in detail at the AC depth and make sure it's uniform and there is no abnormal AC depth in one quadrant. The iridolenticular gap, which is the space between the anterior lens capsule and iris, may be increase in an area where there is a zonular deficiency, the presence of pseudoexfoliation, phacodonosis, iridodonosis, the lens morphology, whether the lens equator itself is visible or there is a scalloped edge of the lens itself visible. A subtle difference can also be picked up if one observes optical biometry anterior chamber depth measurements. Too high or too low a value when compared to the other eye, any asymmetry can indicate that the lens is sitting either too anterior or posterior because of zonular weakness and consequent subluxation. Of course, this has been described that phacodonosis is best examined in the undilated examination with the ciliary muscle under minimal stress and the zonules are not being taut. So subtle degrees of phacodonosis can be picked up in undilated examination over dilated examination, which could mask it. And supine examination again is recommended to make sure that the lens itself is not falling backward when the patient is lying down, which is going to be the position during surgery. So I think the main thing to recognize with zonulopathy is actually recognizing zonulopathy during surgery. And this can be at various stages of the surgery itself. And during capsular rhexis, one might face a difficulty in initiating the capsular rhexis itself. Puncturing the ALC becomes difficult. There will be wrinkling of the ALC when the rhexis is initiated. There is a tendency in greater grades of zonulopathy for the whole lens itself to move around when the rhexis is being performed. And there is a tendency, because it is not taught, for the rhexis itself to radialize. And paradoxically, this causes the surgeon to try and not allow it to run off, and you end up with a smaller rhexis more often than not. But this is better than a radialized rhexis because one can always, in this fashion, perform a two-stage rhexis where a double rhexis, you can make a tangential nick in the ALC margin and then complete a rhexis to the desired size before phacoemulsification is commenced with. So during phacoemulsification, there are signs that tell you that the zonules are weak. Any displacement at any point in time of the anterior lens capsular margin and any sort of abnormal movement or phacodynamics that's occurring during surgery is an indicator that the zonules may be compromised. Of course, we all know that the peak pupil intraoperatively shows us that there is vitreous in the anterior chamber, whether it's from a PCR or from a ZD. During irrigation and aspiration of cortex, there might be frequent unintentional aspiration of the posterior capsule by the aspiration probe tip, and the star folds that you see here developing are much more common in the patients where zonules are generalized and a generalized weakness is present in these zonules and the PC is not taut. The so-called trampolining or the hypomobile posterior capsule that is seen in these cases. And one can, if one looks closely after the end of surgery, some amount of lens matter or debris being behind the posterior capsule without any PCR is often a sign that this material has traveled to Berger's space via defect in the zonules. So coming to a few cases, here the rhexis itself was uneventful. We're having a reasonable mobility of the nucleus on rotation. We're going ahead and chopping this rather brittle white cataract is not very hard. We do notice that there is an abnormal movement of the back, but I'm proceeding with the surgery, hoping that since it is soft, I can control my phacoemulsification. But I do see that there is quite a bit of movement. I use some HPMC to tamponate the capsular fornix at the site of gross movement and continue with very controlled phacoemulsification, being very slow and switching between the foot position 2 and 3. Slowly but surely chopping and sub-chopping all the pieces until phacoemulsification is almost completed. I feel that using an IOL scaffold here would be better, lest I puncture the posterior capsule with the phaco tip. Once I put in this hydrophilic monofocal lens, I continue with the rest of the phacoemulsification. But here you can see that this is not sufficient. I should have probably used a capsular support at this point, and that's what I decide to do now. I put in a capsular tension ring into the bag with the IOL already in place. And once this is done, I don't see this abnormal phacodynamic. I don't see the bag moving towards the phaco tip while I emulsify the remaining pieces. If one observes closely, you can see that there is peaking of the pupil at this point and the iris is prolapsing through the side port where the chopper is, and that's because the vitreous is already at this location. I perform a quick anterior vitrectomy over here. If you look at the red glow, you can see some few white particles from a little bit of tricot that I've used before the surgery. A triamcinolone is a very useful aid to kind of check for vitreous at the end of surgery, and once it is not present, we know that the case can be successfully and safely closed. This is another case here where the zonulopathy itself was recognized and acted upon at an earlier and probably the right phase of surgery. There is some amount of subtle movement of the cataractus lens while I attempt to complete and fashion the capsular rhexis, but this does not preclude the completion of capsular rhexis of desired size. I go ahead and proceed with hydrodissection in a sweeping motion here, hoping, being a little bit gentle because this is a dense cataract. I'm not very confident giving a hydro, but you can see there is quite a bit of movement of this cataractus lens along with the bag complex. So I decide that it's time to put in the capsule hooks to proceed with safe phacoemulsification. Perform 4 stab incision at the limbus to insert the Makul style capsular hooks or capsular retractors. These are longer than iris hooks and they go ahead and support the capsular bag until the fornices, whereas iris hooks, if used, would just tent up the capsule. Now I can easily achieve nucleus rotation and perform safe phacoemulsification, going against sculpting a small groove. And once the initial chop is achieved, the rest of the surgery is quite routine. Of course, one can be slower than what one normally does. And with the last piece done, we can go ahead and while the capsule hooks are still in the eye, complete the cortex aspiration as well. And finally, place the CTR before the capsule hooks themselves are removed so that we don't accidentally damage or propagate the damage in generalized zonular weakness while putting the CTR in. So after this is done, the planned IOL can be placed into the bag after the capsule hooks are removed. This is a planned 3-piece lens which sits quite nicely, and after the visco aspiration is done, you can see that there is no vitreous in the anterior chamber and the case can be closed. This is what could happen if the capsular bag is not adequately supported during the implantation of a capsular tension ring. This was an uneventful surgery, but zonular weakness was noticed. A successful phaco was completed, but as the capsular tension ring is being threaded into the eye, one notices a gross displacement of the bag, and if one were to continue at this stage, you probably lose support of the remaining zonules that remain at this inferotemporal quadrant. So the surgeon stops and puts in some HPMC into the bag, inflating it, providing a little bit of counterforce so that the CTR can be threaded in successfully into the eye. So either have the capsule hooks or capsule retractors until the CTR is in, or if it's possible to do this with visco alone, make sure that the bag is inflated when the CTR goes into the bag. So with another type of zonulopathy, the traumatic cataract, these can be well managed with laser refractive cataract surgery. A femto laser here, again being decentered with the rhexis so that it's on the visual axis when the bag is in the right place after the bag is stabilized. Here again, the intraoperative view of the same patient. This is a very soft cataract in a young patient. The rhexis is gathered first before the rest of the procedure is commenced with. Once this is done, hydrodelineation is performed. This is a very soft nucleus, endonucleus complex, which is made quick work of, and the cortex aspiration is completed very carefully. The CTR is threaded in, and the lens can be placed into the bag safely. So certain situations don't ask the question, can phacoemulsification be performed in this case, but it's rather should phacoemulsification be performed. In this sort of a black cataract, the chances of having intraoperative zonulopathy and propagating the damage iatrogenically is a lot higher. And it's possibly better in these cases to proceed with a large rhexis manual small incision cataract surgery. One can go ahead and create a 7mm plus capsular rhexis and wheel this black nucleus out of the bag and into the anterior chamber quite atraumatically and quickly. And it's not just zonular damage in PCR, but the risk of a wound burn and corneal endothelial damage are also minimized. And you can place in an IOL. If one is well versed with the temporal section, that would take care of, against the rule, astigmatism as well. So it's always worth considering this for such cases. To summarize, the pearls would be recognize the signs of zonulopathy early. This would lead to better outcomes when intervened upon. Tripe and blue or tricot are friends during the surgery. They often help in all surgical maneuvers. Capsule hooks are invaluable and can be used at any stage of phacoemulsification. The adage of the capsular tension ring being used as early as needed but as late as possible. Laser refractive cataract surgery can simplify capsular excess creation in these challenging cases. One can consider a manual small incision cataract surgery to eliminate iatrogenic trauma to the zonules altogether. Thank you.
Very well covered, Rakshit.
Thank you, Dr. Rakshit. I mean, while Dr. Titial is getting ready, any comments, Gaurav? Any important take-home messages?
So in fact, you summarized it so well in your last slide because you covered up all the points really well. And yes, the important thing is to differentiate between generalized zonulopathy and focal, because the management will totally change, and very nicely manage that last SICS with so if you have that art with you, you can kind of deal with those cases as well. And yes, laser cataract surgery in these patients with pseudo exfoliation and other situations which have generalized zonulopathy is a very, very good tool, because it minimizes the stresses on the capsular bag, and that can really help us get much better outcomes. So I think you've covered it really nicely.
I think one comment on this, Rakshit, very nice presentation. Whenever we have the progressive disorder which is causing jonular weakness, maintaining that bag for long run can be difficult sometimes. So sometimes I would put, after do a good phaco also, if the bag is still there, but I'm not very keen to put lens in the bag in those cases. I might put a 3-piece lens in the sulcus and maybe capture a little bit. Sometimes I don't do capture also because this bag is not going to be stable. So that can be one option. If you feel your zonulopathy is too much, it's better to disregard that bag and put the lens in other areas.
So the lens bag complex dislocating the chance you don't create.
Correct. Yeah.
Noted, sir.
I just want to tell you that I'm really impressed the way, with the clarity that you showed the various options and variety of situations. And you also showed that you can use both the retractors and the re-only ring. Don't hesitate, but do whatever you have to do it. So very well done. Thank you.
Thank you, sir. Thank you.
Thank you. Next we go on to Dr. Titial, who needs no introduction, and he's going to be talking to us about his top pearls for toric intraocular lenses.
Thank you, Dr. Ramamurthy, for kind inclusion in this very, very interesting instruction course. Good evening, friends. Every step of surgery can be pearl, but I would like to summarize this in 3 different zones. One is looking into a preoperative pulse, investigation-wise, diagnostic-wise, and second would be taking you to a surgical pulse, and third will be a post-op management pulse. So let me take you through the initial investigation, patient selection for these cases. We all understand if you are putting a simple monofocal lens, anything more than 1 diopter in corneal cylinder should be corrected. If you are going for a multifocal, trifocal or a EDOF lens, even less than 0.75 may need to be corrected in these cases also. These are cases where your toric lens may not work effectively. If you look into that, irregular astigmatisms with a corneal scar, corneal ectasia, glaucoma drainage devices, prior vitreoretina procedure, poor pupillary dilatation, or there is a posterior capsular dehiscence, jonular instability, which Rakshit talked about. These are poor candidates. If you have poor ocular surface also, that needs to be taken into consideration. Manage that first, then go for other cases also. Just showing the biometry of one of my case. This is a patient came to us for a simple monofocal posterior chamber IOL implantation. If you look into biometry, patient has a significant cylinder of 2.4 diopters. So definitely this patient has to be counseled for a toric IOL and it should be considered. This is a patient came for a premium IOL and looked for a trifocal IOL for this patient. But cylinder, if you just look into total K, 0.76 diopters. So normally you might disregard this in a normal manual phacoemulsification surgeries. But looking into this patient requires, if you go toric calculation for this patient, requires a T3 implantation of our trifocal lenses. So it's a very significant to look into your biometry very, very carefully and discuss in a various presentations also. Biometry should be the first investigation in a virgin cornea so that you don't disregard that. This is what we talk about, TFL stability, look for a grade of cataract in difficult situation, stabilize the ocular surface. But looking for axial length, nothing better than optical biometer if you have that. If you don't have that access, then look for a second option, can be immersion biometry, which can be as accurate as possible. Keratometry or corneal power mapping can be done various instrumentation, but make sure whichever instrument we use, that should be well calibrated. And that is very, very important thing. Calibrated equipment should be there. Even you use optical biometer also. Always try multiple measurements to enhance the accuracy, and look for two important areas. If you have a similar steeper corneal meridian, in these cases by 2-3 devices, you have a better cornea. That means patient doesn't have irregular astigmatism. The magnitude or toricity may differ a little bit, but if your axis is matching, that case is a suitable case. See, this is a biometry being done by my technician. This is not accurately placed into fovea. Even a patient still can give you a lot of cylinder. So this patient shows around 2 diopter cylinder, which is not correct. So if you have proper centration, you can see the well centered, the fixation up to fovea, and you see the corneal mire right on the center. So those things will also be checked by the patient. Patient having a poor ocular surface. See, these mires are distorted. This tells you that your cornea is not stable at that time. Put 1 drop of artificial tear, or do it after half an hour, the readings will be more accurate. In fact, this patient doesn't require the toric IOLs. Always look for the anterior corneal curvature, which may be against the rule or with the rule, but we know that posterior corneal curvature is always against the rule. That make a difference in the final calculation. See this biometry here. If we would have taken only the anterior corneal curvature, this was 0.89. But if you see, because the anterior is also against the rule, the actual correction is 1.18 diopters. You would have undercorrected this patient as such, especially for a multifocal, trifocal lenses. It has to be taken into consideration. See this, from T3, 0.5 diopter residual. If you go a T4, 0.02, that is the difference which makes. The other important criteria is how to measure posterior corneal curvature, and which type of instrumentation are required, and this is the various tools which can give you a various assessment. If you don't have instrument which can detect the posterior corneal curvature, you can go through a various nomograms which tells you that what would be the posterior corneal curvature in these cases also. IOL power wise, always take those calculations or those power formulas which takes into consideration posterior corneal curvature, effective lens position, apart from the other areas of these concerns also. If you have access to a higher intraoperative aberrometry, that may be helpful. What are the pulse I like to suggest here? For implantation IOL power, selection should be within 1 diopter or so. If you are going multifocal, less than 0.75 also should be considered. Any device which takes into consideration posterior corneal curvature, a better device. More accurate devices are the biometries which takes into consideration OCT data also. Formula wise, always go for a formula which takes into consideration posterior corneal curvature and the effective lens position also. There are various formulas available online that can be a good way to look into. The second area is the surgical consideration, which you all have been doing very effectively. I think measuring the corneal astigmatism, steeper axis is very, very important, and putting a marks on the cornea is also very important. So you can do a manual marking, you can do image-guided surgeries, or you can have intraop aberrometry. That can all be effective in these cases also. So this is an image-guided surgery which I am showing, which gives you a regular area of incision always, and also give you a guided rhexis orientation also, so that your effective position of lens can be placed better. Because it is important to have a uniformity in making rhexis also, and these guidelines are always better. Many of you may be doing a marking on a cornea, and that also can be satisfactory. Surgery should be simple so that you don't damage the posterior capsule. Once you clean the posterior capsule, implant the lens. Idea here is not to leave any viscoelastic. That is one of the important tip to taken up. Go underneath the IOL, don't worry. Remove the viscoelastic, then place the lens in the desired axis and hydrate subsequently also. These are open J-loop haptics. Sometimes they rotate when you hydrate it. This is one example. I'm removing the viscoelastic here. This is my axis of orientation, 111 degrees. So I place a lens quite accurately now. You can see it is right accurate here. Now I'm hydrating the wound. By this time, with the hydration, the lens would shift. So this is shift, clockwise. So this lens cannot be rotated anti-clockwise. So that's why there's always a tip. Keep your lens little anti-clockwise when you are doing the hydration manipulation, so that you can shift the lens clockwise, which is easier also. Manual marking should be, very sharp. I think that is very important tip which people might miss. And if you have these three markings, 3, 9, 6 o'clock, the orientation is better. And if you have a sharp markings, your lens placement axis will not deviate much. If you have a fuzzy, hazy margins, things can be difficult also. But if you compare manual versus image guided seems to do better. Especially this is useful in cases where you are implanting trifocal EDOF lenses, which will be very, very important to have a very accurate orientation with your lenses. To give us some pulse in this, manual methods are good. If you have a pendular markers, accurate positioning can be done. Image guided are always better in terms of giving you a better quality of vision with your trifocal, multifocal lenses. Intraoperative, if you have, it's a good adjunct to difficult cases like a post-refractive surgery patient where sometimes the corneal biometry can be tough in those cases also. Last bit on how to look into a post-op alignment. These are predisposing factors. And most importantly, your accuracy might change because lens might shift in a post-op period. Within a 1 hour, seem to have a maximum rotation in these cases. If you leave viscoelastic, rotation will be there. How to make a decision in these cases, which cases might benefit by rotation. So this is a simple analysis. The rotation may not help if you have a spherical equivalent more than the cylindrical error. If you have a cylindrical error, which is more than a spherical equivalent, this patient is going to help by rotation. See here, the spherical equivalent -2 diopters, but the cylinder is one diopter only. You can correct this only. You can't correct the spherical equivalent because your initial calculation was wrong. But if you see here, a spherical equivalent 0.5, but your entire other area is more. 1.5 cylinder is seen there. This is the patient which will benefit by rotation. And before that, look for a visual acuity uncorrected, perform refraction, show the refractive cylinder now, dilate the pupil, see what is the new orientation of lens and what was your corneal cylinder. That is the rotation required for this patient also. You have various softwares which can guide you to rotate and how much correction can be done with these also. This is one device I use regularly, iTrace, which looks into enhancement software, gives you how much rotation is required and how much correction can be done with this. And if you take the patient, rotate, and subsequently you get up. This is the post-ops, 1 degree rotation, no rotation required, good alignment. To summarize the important points in a post-op, check in a toric IOLs, check for a toric alignment. If you have rotation more than 10 degrees, less than 6/9 vision, you might have to take patient back to OR. And these are various ways you can check the rotation. Look for various formulas which can give you a better way to judge your patients. And realignment should be done within the first week or so. But if you have a larger bag, you might wait for some more time. And especially in those cases, you might have to take with the image-guided surgery again for second time. This is a review article in IGO. You can read and gives you all the details. And thank you again for listening to this talk. And thank you, Dr. Ramamurthy, for giving this opportunity.
Thank you, Dr. Titial, for that wonderful exposition of the entire array of toric intraocular lenses. My go-to formula for my basic IOL power calculation is the Barrett toric calculator, because I straight away upfront I want to know whether toric is indicated or not, which takes into consideration the posterior corneal astigmatism. It's not universal too, but toric calculator.
Absolutely correct. So normally what our standard ways to go for a universal first, but whenever we are going for a patients requiring EDOF or a trifocal, we always say go for a toric formula right from the beginning. That tells you exactly what is the current scenario for that patient. Good point.
Thank you.
Yeah.
Now we have our Dr. Gaurav Luthra from Dehradun, an excellent cataract and refractive surgeon and always a tech-savvy person who's going to talk to us about laser cataract surgery pulse. Please hold on. We have saved the best for the last. Dr. Asavda is going to talk to us about pulse in heart cataract surgery.
Thanks, Dr. Ramamurthy. And I'll immediately go on. Thank you for asking me to speak on this topic of laser cataract surgery pearls. I'll try to take you through the various situations where laser cataract surgery actually scores over conventional cataract surgery, and then we'll see how these get influenced by the various ways we can get the best out of it. So intumescent cataract remains one of the very, very important indications, and if you'll notice here, this is a really, really intumescent cataract. You can see these vacuoles with clear fluid, which can be easily seen even on the slit lamp, but more easily on the OCT, even on the anti-segment OCT, and these are the ideal cases where a laser cataract surgery will work to prevent runaway rhexis or a flag sign, Argentinian flag sign. So, of course, even for laser cataract surgery, there are challenges when you are dealing with these intumescent cataracts. You may not get a complete perfect rhexis on these patients because the moment there is decompression, as you can see, there was that sudden burst of when the lenticular pressure was released. So as soon as that happens, sometimes there is the lens thickness goes down, and some of that fluid from the lens will come out into the anterior chamber, and the plane of the capsule will change. So once you do this, you must stain it with trypan blue. In fact, all semi-opaque or opaque cataracts, it's a good idea to stain them. And you have to, if you see the way I'm kind of trying to complete the rhexis, even though it is actually complete, but I'll go back again over there and just see the motion, because it has been shown in the past when we were into femtos that you can just pick up the rhexis over there. But in many of these cases, if there are small islands of adhesion still left, it's a good idea to just do it just like you would normally do a rhexis with a forceps or with a needle, whichever one way you like, because that way you will not have a broken rhexis. And the incidence of broken rhexis with intumescent cataracts in femto-assisted surgery is extremely low, but then you have to obviously deal with it more carefully. So you can see that we were able to get a good rhexis over here. And eventually you can, of course, much has been spoken about the strength of the rhexis as well. And I would like to say here that, we've been doing, most of us, Dr. Tetial, Dr. Ramamurthy and Dr. Vasavada there, all of us have been doing femto-assisted surgeries for long. And I think, would all agree that the strength of the rhexis remains pretty good, whether you're doing a femto or a manual rhexis. We haven't really found a difference between the two. Going on, I wanted to just share this one small situation which was important to share. When you do a femto-assisted surgery, the rhexis of course comes out beautifully, but so does the cortex. So the cortex gets cleaved right along the plane of the rhexis. So you'll have about like 50 microns or 100 microns of cortex which is cleaved exactly under the capsule, and it becomes a little difficult to sometimes get a hold on it, and it takes time to get used to it. So here I wanted to pull out a video where you can see that the cortex is cut exactly along the same plane as the rhexis, and I'm trying to remove that, and I'm doing quite well there. And now I'm going to the other side, and the moment I go there, you can see that I created a zonal adhescence. So when you're doing a femto-assisted cataract surgery and you're doing a rhexis, it's important to ensure that the cortex, which is cleaved just exactly under the rhexis plane, there is a small chance that you will hold that and you will get into this situation. Now here I'll go on to our next situation, because you will obviously learn how to deal with that once you start doing cataract surgery with the laser assisted surgery. Now another indication where I think that hard brown black cataracts, they have a great benefit from laser assisted cataract surgery, because these are not opaque cataracts. So these are those hard brown black cataracts where you can still possibly see a glimpse of the fundus, and you can see that the situation here is a significantly dense cataract. And you can then plan your fragmentation using several different techniques. You can have a double pass of the energy. You can have closer spot size, or various ways to do that. And you can even do the fragmentation using the grid pattern. I like to do a 6-quadrant crack. You can see that it's a really, really hard cataract. And then you can, because of the cavitation bubbles, usually it is possible to rotate these nuclei, but one should not use extreme force because there's almost very little cortical cushion. And these cleavage planes will usually form nicely in these hard cataracts because these are not opaque. So femto energy, unlike intumescent and mature cataracts where the laser energy won't penetrate more than maybe 50 or 100 microns, in these hard brown black cataracts, the laser energy actually penetrates quite well because they are still optically allowing the laser energy to pass through them. And you can then have these cleavage planes, and as you can see here, it becomes much easier with very little force as compared to what you might do under a routine case like this. You can do a separation very, very easily. And once you've separated all the quadrants, it becomes nice. In fact, it's much easier to crack the posterior plate as well. And of course, it's a good idea to use a viscoat cover for the endothelium, and you can then go in with a injector system like this, which can deliver the lens straight into the pupil, into the bag. and you can see that the pupil did come down a little bit. So of course this was fast forwarded, but hard brown and black cataracts are a good indication for laser assisted cataract surgery. Now going on to another technique where again it might seem counterintuitive, because we've been taught right from the beginning that it's not a great idea to use femto assisted cataract surgery for RK eyes, but for me it's a very, very good indication because of many reasons. Usually these are high myopic eyes where the chamber depth is much more than usual. Also there's a chance of the lens iris diaphragm moving backwards once you have switched on the infusion. So in RK eyes, the essential thing is that you have to look at the landmarks because the corneal curvature is very different. So when programming the laser, you have to just be careful to watch out for any changes that may happen and reset them, adjust them accordingly. Now you can see here that this is a fairly hard cataract in an RK eye. Now when you do rhexis, in these cases you have to be very careful to watch out that the rhexis is complete and there are no tags, because you can, in fact, if I show you a small tag over here, which again if you use the same technique, if you monitor here over here, there'll be a small area where there will be an incision. So just under the incision there may be small attachments. So if you're using the same way of tearing the capsule as I showed you in that previous clip, you will usually not have a problem, and you can nicely see this small discontinuity here, which is just like a small irregular bump over there. But frankly, in RK eyes, the advantage is that your manipulations inside the chamber are minimized when you're doing a femto-assisted surgery. But then you have to be careful that you remove the capsular redundant capsule very, very carefully. Otherwise, you'll have a break in the rhexis, and then you can even go with a toric lens if you have to in such eyes. So fibrotic cataracts, again, I feel that while the laser may not be able to cut through completely, but it does give you a very nice postage stamp kind of a tamponade. You can see the capsule here. The entire capsule is so irregular and fibrotic, and once you are programming the laser, you can increase the depth of the rhexis and increase the energy as well, because that way you will be able to get a better outcome. So you can see here that I'm correcting the size. I'm also using some other adjustments since it's a hardish cataract, and you have to make sure that your the capsular landmarks are set correctly, and then I'm increasing the vertical extent and the energies, and then I'm firing the laser. Now you must stain these capsules, and I have seen a very brilliant video by Dr. Ramamurthy as well, who shows very nicely the same thing. You can see that the template has been formed, and while it may not be a free floating rhexis, but it does give you a very, very good way to kind of, just like a postage stamp, just deal with it. Because otherwise the only other way would have been to run a micro incision, micro scissors, and cut these capsules, because there is no other way to deal with them. So a femto assisted situation here works extremely well, and you can see that it was a very fibrotic cataract, and then of course the rest of the surgery is mostly uneventful. This is a posterior polar cataract. Again, we've already had a very nice lecture covering posterior polar cataracts. My preferred way of dealing with posterior polar cataracts is with the laser, because you can then reset the posterior benchmarks, and you can see that the landmarks are there, and you can very nicely see the posterior polar cataract over here. Even with a pre-existing break in the posterior capsule, you can do a very good job with the posterior polar cataracts. You can see that I'm now setting the posterior offsets and then preparing the laser. And here I'm going to change the posterior offset so that I increase the safety margin for the posterior capsule, because that's the area where the posterior polar cataract is limited. So now we are going to fire the laser, which will not reach beyond the 700 micron safety margin from the posterior capsule. Now this ensures that you also have the 6 quadrants of, 6 fragmentation of the nucleus is done. And this ensures that you get a good situation. Now once you have achieved this, you have a perfect rhexis as well of the perfect size and situation, so that if you have to do a optic capture of the lens, intraocular lens at the end of surgery, God forbid you get a posterior capsular break, you will still be able to do it nicely. So I will not rotate my nucleus at all over here, and my 6 quadrants are already formed. And then I can just gently ease them out without doing any rotation, as you can see over there. I ease out a third one because your template is already formed. The 6 pieces are already formed, so you don't have to go into the situation cracking them. And it also leaves a nice cushion of epinuclear shell, which is going to remain right till the end. And once you're done, you can again do intraoperative OCT and ensure that you can see that what is the situation, how strongly adherent it is. And here I would then also try to disengage all the cortex from the equator of the bag and ensure that it is nicely separated out before I attack the small segment of the posterior pole. And I'm now going to remove, leave just a small rim of cortex all around that posterior pole, and then I'll do either a viscoflotation or a hydroflotation of that attachment of the posterior pole. So in that sense, the femto-assisted laser becomes very, very useful, but you have to be careful. See, I'm not even now ready to go very close to that, and it's only towards the end when I'm sure that I've removed, debulked it completely. Now I'm going to do a visco separation. I'm pushing viscoelastic from the periphery, lifting up that small epinuclear plate, and then ensuring that I'm not going to aspirate it. I'm just going to gently move it to one side and see that it separates. Usually it separates very well, and you can see here that now we've been able to get it off without creating a break, and this really becomes useful. So I think I'll stop with one last case, and this is a situation of a small pupil. I've injected phenocaine, and I'm planning a femto-assisted surgery because the pupil was so small that I couldn't have proceeded with that. So I just make a small micro incision of less than 1 millimeter, and I inject phenocaine. Now this gives me a pupil size which is sufficient for me to now proceed with a laser-assisted cataract surgery in a small pupil. So of course some people like to put a BHEX ring or a Malugins ring as well. Now you can see I'm changing the landmarks because I'm resetting the pupil size to make it slightly bigger than what the machine detected, because that will make it easier for me to get a slightly bigger rhexis than what. So from a 3.8 I've been able to increase my rhexis size to almost 4.1 by resetting the pupil parameters on the machine. And then I can proceed with the surgery as it would be for a usual case. So this is one way of dealing with laser-assisted cataract surgery in small pupils. Another way for that might be to use a small ring, but then you have a slightly bigger incision to deal with. So I think I've run out of time. Again, I would not show you videos, but great indications are shallow anterior chambers with pseudo-exfoliation, high hyperopes. I'll also, even with the post-ICL, I prefer to use femto-assisted surgeries because you can get your rhexis very nicely. Only caution is that you should, if you have silicone oil in the chamber, then that becomes a problem. And subluxated lenses, so I would have shown you these, but for the lack of time, because there are so many situations to deal with, I think I'll stop. And these are the indications where it works really well in my hands and in many others' hands, but there are limitations. And I think with that, I'll stop. Thank you so much.
Thank you so much, Gaurav, for that comprehensive coverage. While Dr. Vasavda is getting ready, just one quick question. While listening to you, it occurred to me, LRCS, we consider it as modern, but so much has changed in phaco, intraocular lenses, the accessories that we use. Anything has changed in the way you do LRCS in the last decade or so that you have been using the machine?
So I think I graduated from the, I was using a Lensex, which used to be, I think the catalyst that I use and also the newer machines that have come out, they are so much better. We are now getting iris registration with there's a link of the catalyst with the ILMaster 700. So the cyclotorsion control is there, the toric LRI planning is there, the toric marks are there. They've kind of reset the energies because now we can do it much faster. We're using lesser energy and lesser repetitions, in the central area. So the skip area. So a lot of programming has gone into it. I think it's become so friendly. And I like to call the modern lasers more like the iPhone compared to what we were doing with the Lensex long back, because it used to take ages, playing with the software, and now you can just do it seamlessly. I can sometimes do 7 or 8, femtos within about 30 minutes for the laser part, and it makes the, the workflows are so much easier and more predictable. So I think it has come of age, except that the corneal incisions I would still think are I don't use the corneal incisions frankly, and I used to use them on the Lensex a little bit, but on the Catalyst, while they make sense, but it slows you down a little bit, so I don't use the corneal incisions, and they are not the most important part of femto-assisted surgery, I think.
Corneal incisions, he means the entry incision or not. I'm sure the...
Yeah, I do the LRIs and I do the toric marks on the cornea, but I don't make the main port. It's much better with the keratome, I think.
Thank you.
Yeah.
And over to our star speaker, Dr. Abhay Vasavda, who's going to talk to us about top pearls for hard cataract phacoemulsification.
Yeah, I just want to comment on the Gaurav. Please listen. I think flex is a very good technology to make incision. Why? Because you can titrate the width of the external incision and separate from internal. What I do is truncated 2.2 millimeter outside, 2.3 millimeter inside. And that I cannot do it manually or any other way. So please, you have the best machine. Please do that. Thank you. Now, I just want to share what I find very useful in dealing with dense and very dense cataract. And preoperative assessment, like all other scenarios, remains of paramount importance. And for me, cataract surgeon, depth of the anterior chamber, space in which I'm going to work, endothelium, and the dilated pupil is the main thing. And then the cataract itself, brunescent, black, postpolar, corticocapsular adhesions, and so on. Very simple. You don't need the OCTs and all the other thing. Would I need a, pupil expanding devices? How bad is the cornea? Are there guttets? And all this assessment is important in every cataract case, but more so in dense. Anesthesia, I would, from the podium, say, do not hesitate to do peribulbar anesthesia. There is nothing wrong. It's an excellent reassuring technique. I do not do it as a rule, but I would recommend as a general that please consider that. It's very good. Incision is something very important, and as I just alluded, I didn't know that I was going to talk on it, but the trapezoidal is very useful general, and I learned it from Dr. Osher many, many years ago. The descemet detachment occurs more often in the main incision, and that's because your external and internal is like a tunnel, and you manipulate up, down, and all this stuff that produces the detachment. So have an internal opening little wider, as the SICS does that trick when they deliver the nucleus out of the antechamber, but only little. So flex or manual, whatever your incision external, 2.2 or 2.4, do a little more internally, so DDs are less and you are free, no locking, no burns. In dense, it is a thermal injury would be seen. So I prefer 2.2, even in a dense cataract. I started with 2.4, but you can with interrupted energy delivery. Capsular axis remains there. I typically do 4.9, but here I want to do a little more, 5.1 generally. And I can do it with like Gaurav and DR with the Lensex, but or the flex. But if you do not have any, you don't need that actually. For dense cataract, you don't need the flex. If you're comfortable, please go ahead, but do a little larger than you would have done otherwise. And always stain with trypan blue, even if the brunescent cataract shows a good glow in a coaxial. You will never know when the pupil constrict, you will not be able to recognize the rexus margin. So always stain the capsular axis. So you can do with the needle or forceps or whatever. But notice, what I did was, I used to do from central puncture in here, but I did on this side also. I made a larger slit, and I'm now pushing this whole capsule in front of that slit away from me. So the both ends of the rexus gives a strong margin. So chances of that going to the periphery are less. And then you continue in your conventional way of, everting and taking your time, and always classical teaching is to go a little bit beyond that starting point, overshoot that. But this is the kind of rexus I'm very comfortable with, the densest of cataract, quite large, which 0.2 or so more larger than normal. This is a normal rexus, but that's okay. Now, where is it? Next step would be hydro. Now, there are a lot of controversy. Should I do it? Should I not? Because the bag is so much stretched over the years, and if you overdo it, you might rupture intracapsular block. On the other hand, these dense cataract quite often have a capsulocortical adhesion, and if you do not do it and stress the rotation, you might produce a problem. So I don't know, but what I now have settled down is to do a gentle, I want to do hydrodissection, number one, but very gentle, not as forceful as I would do. And if I find that it has gone a little bit at one place, I won't repeat that in another quadrant. And I can always repeat that if I find struggle. And that's because of this corticocapsular adhesions that was described in 2003, more common in the white cataract, dense cataract, younger people, cortical cataract, and so on. So I use this Akahosis modified locally made cannula, which I find useful. Whatever you're using, bend a little bit towards the curvature of the lens, not the classical teaching of cortico-cleaving hydrodissection where you tend the anti-capsule up. No, follow the curvature of the lens, little down, and very gentle hydrodissection. And if I'm happy, you can't see the wave, and don't try to see also, you will never see that. So that's fine. This gives me an impression I'm okay, but it's a feeling, proprioception. If necessary, always be ready to repeat that. But I think it's important to do that. Now, this is the real thing. How are you going to remove this? I think we should have in our mind a clear concept of how the lens is removed. First, creating a space, if you want to believe that. Then division, different parameters for division, and then removal of the divided fragment. So complete the division first, and then go to the removal with different parameters, particularly in this dense cataract, where you want to protect the capsule as well. So creating space is a good idea. You can do it direct chop, but in these bulky cataract, I would recommend strongly, you may spend 3 or 4 millijoules more energy, but it's worth. But you want the depth more than the length of the trench, and you can actually go as deep as you can. Dr. Gimbel described years ago downslope sculpting or whatever, but as deep as you can, but not stressing the subincisional zonules. The Kalman tip and bend tips, 45-degree bevel is the right combination for a dense cataract. Now, next stage, as I said, is the division, division. But notice the parameters. You don't need a vacuum. You just want a vacuum to run the pump. 50 millimeter is enough. Not too much of a flow rate, but sufficient power. All right, so that's having done that. Now, the next one would be the division. And that is really key, and the aim is to have a complete division of the entire anterior posteriorly. Whatever the chop maneuvers you do, direct chop, Nagahara, horizontal step, vertical, do in a step-by-step manner. That's the essence. And when I say step-by-step, same thing whether horizontal or vertical, create a crack. Do not aim total division at one stroke of the chopper or like that. The whole lens tilts in horizontal, and there you can repress. So create a crack, place the chopper into the depth of the crack you created. Once again, repeat the maneuver. So progressively, in a step-by-step manner, take that thing that you created. And notice here that the vacuum will go to the highest. The foot pedal is in third position. And once it occludes completely, you want to come off to the second position. The 3 figure will become 2. Now I have lifted my foot up. So total vacuum achieved. And then initiate the crack. Do not aim a karate chop, one division. And then place the chopper into the depth nearer to the posterior plate, and you can remove the occluded tip and re-block it, as I call multi-level. But whatever, take in a step-by-step manner and not one stroke. And you can have different examples with the different grades of cataract. Whatever maneuver, go in a step-by-step manner. Do not aim one stroke. These cataracts are very dense. They look okay when you see the red glow, but they are really quite leathery and tough. So you go through that, all that. You can do that in a small pupil. I would recommend you to use the pupil retractors or a ring expansion, not this. No ego, but I'm showing you just to prove that this kind of movements is quite safe. It's not a blind procedure. You're able to see everything even through the small pupil, and you can achieve the goal of total division. Continue that 360-degree round and make as many fragments as you can. And once again, the similar thing, loose zonules, high myope, floppy bags, it will work every time. And I don't do this technique every time. I do straight direct chop sometimes, horizontal chop after space. Whatever I find good in that particular area, I would do that. And the same thing, total division, first in 2 halves, and then you start occluding. I learned from Dr. Paul Koch, I mentioned it in the earlier hall, that reduces the stress to the entire back. If your total division in 2 hemisphere, whatever maneuvers you do will be restricted only to that part of the hemisphere and the capsular back. So it's a good idea before you proceed to a total division in multiple fragments, create 2 distinct separated fragments, zones. And then you do that. This is a direct chop, straight away. You see the milk coming out with so much of energy in an occluded tip is a waste of energy and loaded. But you can do that. But notice the whole lens tilt, because I am aiming at total division. I don't think you need to do that. But there is nothing wrong if you have a control and go once again progressively deeper in the depth. You may have to have a whatever expansion device you have, but same thing, you can do that, the horizontal chop in this cataract. It is little more effective than what I showed earlier, but the safety margin is little reduced in this technique compared to the one where you go in a chop in situ step by step. But now you can impale this tip once again in the depth and bring the chopper there. You can do in a small pupil like the other one. It depends on how much practice you have in a particular action. Now, posterior plane, as I said, is important. I think we are done through that. And multi-level chop is the same thing. It helps you with minimal stress. Start the division, take both the separating forces, the occluded tip and the chopper, again nearer to the plate that you want to divide, so that you don't have to have a lateral separation movement as much as you would do otherwise. And this illustrates what I'm saying. I'm taking this occluded tip once again and re-occlude it again at the depth, and then I could achieve that crack very well. Once again, similar thing. Now, finally, fragment removal is the one which will decide clarity of the cornea, because if you are in the anterior plane, you would be difficulty. So, first thing is produce as many small fragments as you can, so they are very easily manipulated, and also be aware of the plane which you are removing. You don't have a slit lamp. I don't have any more now, but be conscious the level of the emulsification and try to be as away from the cornea as possible, and therefore you need a low aspiration flow rate so that you don't rupture and threaten the capsule as well. And repeated use of dispersive viscoelastic containing chondroitin sulfate is really very useful and very protective to assure a clear cornea day 1. And we had a rule, 1 minute of clock time or 2 minutes depending upon the endothelial health. I would be given a viscoat or a chondroitin sulfate in my hand, and we'll keep injecting every 2 or 3 fragments the viscoelastic there. So I hope it comes here now. But notice the low IOP, low flow rate, and even with this low flow rate, 20, it comes up very well. So this is what I meant. Keep injecting viscoat and continue doing that. Flex, as Gaurav has said very well, whatever you do, you want to have this as an aim. I don't produce this every time, I must say this. But this is one of our good ones that I want to show that clear. But the final pulse is counseling. Tell all the possible eventuality like this one, PCR, and change in plants and so on. Explain to the children as well, not to the patient itself. But technically speaking, go slow, step by step, aim complete division, multiple fragments, try to remain away from the endothelium, general use, and have a backup plans. And finally, once more, again, to remind you that there is a APS-CRS meeting coming up second time in India after 12 years in Ahmedabad in August. And particularly for juniors and beginners, I would recommend very strongly because it's really a quality teaching by the masters there. Thank you so very much, DR, for the opportunity. Thank you.
Thank you for that excellent exposition. Just one quick question. All you showed was direct chop techniques, varied direct chop techniques. It seemed to work very well in your hands. What about stop and chop? You know, many of the youngsters may be more adept at that, creating a deep division and then cracking into two heminuclei and then subsequently dealing with
that. Is the best. That is the best, and I do that. I just showed the different ways of chopping, but I did, I think, mention, and thank you for bringing it up. I cannot agree more with you. Creating a space is very important in all cataracts, but particularly in this dense cataract. And it will reduce that force and the power and everything. So, yeah, I agree.
In fact, I think you did show one where you had made the trench nicely, you know, quite deep, and then you did the, you know, direct chop. That itself, you know, works really well because you've created space, you've debulked the hardest part of the nucleus, and then you kind of go into it, so it works well.
I think that's rational you brought it. I forgot to say it the way you say it, but that's very good. I think my point is, you have your trick, and you have to change your chop techniques every case, or even in the same patient. You start with that and then you find that I'm not able to go direct under the capsule. Don't worry, start horizontal or the vertical and so on. So have many tricks up your sleeve. You can use multi-level, you can do this, that. There are ways of, and everyone has their own tricks and everything works.
I think the bottom line is to break the backbone of the nucleus.
Posterior plate complete division is the real key.
Thank you so much, and thanks for the wonderful faculty who made it all so interesting. Truly appreciate the delegates for joining us and staying back right till the end. Thank you.